Good morning and welcome to this second MDU webinar in our e-remedies series. My name is Dr. Udvitha Nandasoma. I'm a medico-legal advisor with the MDU, and this morning we'll be talking about complaints. And we're going to have an interactive webinar, so please get used to using the chat box on the right of your screen to fire off questions, and there will also be scenarios where I'll need your input into those. I'll try and deal with the questions as we go along, and there'll be some opportunity for questions at the end. Complaints can be a difficult and challenging area of practice, and they can be really time-consuming, but effective complaints handling can really pay off, and that's the aim of this webinar today. The one thing I'm not going to do is to overwhelm you with technical information about the complaints process. We've got a lot of information on our website about that, and often those questions come up when you're in the middle of dealing with a really complicated complaint, and in those circumstances I'd always say, look, ring us up, and that's what we're here to advise you on. So without further ado, I'm going to make a start, and I will disappear and the webinar presentation will come up, so we'll just make a start now. So as I said this morning, what I wanted to talk about was complaints, and firstly I want to talk a little bit about why it's important to get complaints handling and complaint responses right. To do that, obviously you need to identify complaints and know when a discussion should amount to a complaint and should be dealt with appropriately. And we'll talk, of course, about how you should respond to a complaint. I'll also talk a little bit about how to avoid complaints. I think people are really very good at doing that already, because complaints amount to a tiny fraction of the total number of patient episodes and consultations that occur in the NHS every day, but there are some tips that I think we can share with you. So to do those in turn, well, why are complaints important? Well, in my job as a medical legal advisor, helping members respond to complaints is part of the bread and butter of my day-to-day work. And in the year 2013 to 14, we had nearly 11,000 requests for help with complaints. Delayed diagnosis and issues around communication were the two top categories. And just to get this webinar started, can I ask you to vote on what percentage you think accounted for each of those two top categories? Well, most of you were absolutely right, that when we look at the top category for things that led to complaints, it was one of delayed diagnosis. Now, this is unsurprising, as many of our members are in primary care and in general practice and dealing with unselected patients, so delayed diagnosis is of course high on the list. I was quite surprised that communication only featured as a key theme in 15% of complaints, but actually when you look at most complaints in detail, a lot of them will have some degree of reference to a communication issue in them, so communication still remains a really important theme. Well, why is it important to get it right now? We know that complaints are common. And most doctors agree that patients deserve an open and honest response where something goes wrong. And quite often when I'm taking calls on the MDU advice line, members will ring me up and say, look, I've already done these things. I've already contacted the patient, explained what's happened. We've done these things to put it right. What else should I do? So often this has already been done. And actually it's often a very good way of avoiding complaints. As well as that natural desire to deal properly with complaints, the GMC does have a regulatory obligation on us all to provide a proper explanation where things go wrong and an apology if appropriate. There's also a bigger picture to this, and that is that there is a spectre of what we term multiple jeopardy. All I mean by that is that although a single clinical incident might result in a complaint, that's not the only thing that could arise from it. It's relatively rare to have a situation where all these processes that you can see on your screen are active, though I have dealt with 1 or 2 cases where that is the case. But on the other hand, it's not very rare for, say, for example, something to begin life as a complaint and there to also be a complaint to the GMC afterwards, or indeed where the patient has died for there to be a complaint and then a coroner's inquiry. The importance of that is really that when you prepare a complaints response, it's helpful if it's of the sort of quality where it doesn't cause you any difficulty in using it in another process or standing by it in another process. So remember that anything you write, and I guess that's the same for even clinical records, could be considered in a process that you hadn't anticipated to start with. So in order to deal effectively with complaints, we need to be able to identify a complaint when we see it. Now, it's interesting to note that the complaints legislation that's present in each of the jurisdictions in the UK doesn't precisely define what a complaint is, and I think it's partly because it's felt that it's something that you know, we all recognise when we see it. And I think a broad definition is really what we need, and I can't think of a better one than it's simply an expression of dissatisfaction that requires a response. Of course, when you leave it that broad, you know, you could put in things that are simply comments and concerns that are expressed to your reception staff or to anybody working on the front line, and it's certainly encouraged that you should train and empower frontline staff to deal effectively with complaints. You know, they may well be able to deal with it on the spot and the matter can be resolved. Again, that's an excellent outcome. Where that's not possible, of course, you've got your formal complaints procedure. And I'd just like to talk about that just for a moment. The reason I say that is that as far as the complaints regulations are concerned, complaints can be made orally, verbally, you know, in writing or by email, and all of those could amount to formal complaints, simply because a complaint is made by a patient coming up and speaking to somebody at the practice or at the hospital doesn't mean it's informal. The only category of complaint that can be properly considered informal are oral complaints resolved within 1 working day. And what that means is that the set of obligations that the underlying complaints legislation requires aren't engaged, and they can be dealt with on that basis. But I guess the main learning point here is be cautious of just thinking because somebody's emailed in a complaint or just spoken to someone that it isn't formal. It may well be. The other thing I just wanted to mention was the real interaction between the complaints process and your governance procedures. The two obviously can work together, but they are fundamentally separate. The reason I say that is, for example, you may be in a situation where somebody deals with an oral complaint really quickly, effectively answers the patient's questions, and they're happy that the matter has been resolved. But that person might think, actually, this does raise an issue for us that we should put through our governance procedure, and it may well be appropriate that there is a significant event analysis or some kind of reflection on that through your governance procedures, even where there isn't a formal complaint as such in operation. Quite often, obviously, the two will work together, but there may be other circumstances where you've got an angry complainant with lots of issues, but they're not of the nature that is amenable for you to look at through your governance processes. So just be aware of that. Of course, the key question we're often asked is, well, look, how do I start with responding to a complaint? And in order to understand that, I think we need to have some idea of what complainants want when we're writing letters, so that we can see something from the complainant's perspective also. And so if I can hand it over to you now, if you can send me your comments on what you think a complainant will want to see in a response. And as I say, use the chat boxes on your right, and hopefully those messages should come through to me as you type them. So we've got a comment here saying complainants might be after an apology, and there's 2 or 3 I've got, Anita and Tamas and Graham here with that, and I'm saying an explanation, and Katrina's come in with a full explanation of the course of events. And we've got empathy here that's been brought out, an acknowledgement of concern, a wish to prevent similar events. And we've got, perhaps they may have other motives such as to expedite their treatment. They may want financial recompense. Got a reassurance that if something does go wrong, it won't happen again. And did it cause a change? We've also got here from Peter here saying that complainants want each issue to be addressed and an explanation as to why, what happened, and also we've got here that complainants need to feel listened to. So that's a really excellent set of responses, and I think that you've got everything that I have on my slide. That complainants are usually after an explanation. They want to know what happened, and quite often putting a really detailed explanation in your response is enough to deal with a complaint, because a lot of complaints are built on misunderstanding. Complainants do need to feel heard. They need to feel as though you've understood the concerns, even where you don't agree with all of them. An apology can be very appropriate and extremely helpful. And they often do want to be reassured that there will be improvements to services. Now, not all complaints raise those sorts of issues, but some will raise relevant learning points. And a willingness to deal with those issues and to put things right is also important. And it really, I think, is helpful when a response conveys the impression that the practice have got, or the practitioner has got a handle on what's going on and has taken ownership of the problem, dealt with it. Now, in terms of dealing with some of the other issues that have arisen, for example, issues such as financial recompense, etc., there's nothing to prevent there being a financial remedy in terms of a complaint, and this may sometimes happen, say, if there's a wasted bus fare or wasted prescription charge when there's an error on the practice. Our view has always been that we don't think the complaints process can allow for very large amounts of financial compensation, that there are separate processes for that. But of course the Ombudsman, who deals with the second stage of the complaints procedure, can award financial remedy as well. Now, I think you've all really identified what complainants are after in terms of a complaint response. There are things that, in our experience, are not helpful in resolving a complaint. These can be where the concerns are simply denied, even where there's some factual basis for the existence of the concern, even if you wouldn't agree with everything the complainant has said, or when those concerns are trivialised. Where there's a perception from the complainant that there's an attempt to either blame them or someone else for what's happened, or where there are explanations that are misunderstood as excuses. Now this can be quite difficult, because of course complainants can talk about trivial issues. There may be circumstances where the patient, or the complainant has been responsible for some of the things or delays or issues that have arisen, and there may well be issues in complaints that are outside the control, your personal control or your organisation's control. I think the thing to say with that is that there is usually a way to deal with that response, to still deal with those factual issues and to get everything, to get the factual scenario explained appropriately, whilst not perhaps falling into these pitfalls. The other thing in terms of complaints handling that complainants struggle with is multiple procedural stages. And when the latest sort of incarnation of the complaints procedure came into being in around April 2009, one thing they changed was to say, look, we're not going to have this three-stage complaints procedure. You have local resolution, which is dealt with either by the practice or the Commissioner of Services or the hospital or have you, or the complainant can then go to the Health Service Ombudsman, so there are only 2 stages rather than 3. From a practical perspective, it also introduced a very significant change, which was that where there's a complaint about multiple different organisations, say for example a person has a gripe with the out-of-hours service, their own GP and the acute trust, then the onus is now very much on those organisations to work together to coordinate a response to that concern, rather than the complainant being pointed to each organisation in turn. So in terms of, well, how practically can you deliver that? Well, I think here are some tips from our experience of advising on complaints. First of all, be sympathetic and strike a conciliatory tone. Now that can be very difficult, but take some time to think over it and seek advice, because it's actually often possible to deal with difficult issues where there's disagreement on the facts, or where you simply disagree with a version of events the complainant has put forward, or even where they're unlikely to be satisfied with your response, where a conciliatory tone can be set. And there's certainly no issue with expressing regret or providing an apology where that's appropriate. As we said, try and avoid pointing fingers and dealing with issues of blame. It's not usually helpful to do that. Where you've got difficult clinical issues, it can be appropriate to have an independent colleague look at the case, and that can be a reassurance to a complainant. Again, in terms of a lot of you have said, look, it's important that complainants feel as though they've been heard, and actually addressing each point in the complaint, even when you don't think it's really that important to affect the outcome, can be really helpful. And a lot of people again have said, look, we want to know that this won't happen again. They want to know that things have been learned from the complaint. And I think that's really important too, and a lot of the complaint responses we see have some really important issues that arise from complaints that are set out in the response. The one thing I would say is that learning points should be meaningful. It's much less helpful to say that lessons will be learned than to say, look, this is what we've done in response to your complaints, these are the changes that we've actually made. The other thing to say goes back to the point that we discussed at the beginning about multiple jeopardy, that it's possible that other issues arise from complaints, or indeed the complaint reactivates matters or goes to the Ombudsman after some delay, and if you said certain things will happen in the way when you're dealing with a complaint, then make sure those are implemented in a timely fashion. It can also be helpful to offer to meet with a complainant to discuss matters further. You can have meetings at the start of the process or reserve them for the end if there are outstanding issues. A lot of those really depends on what the complainant wants and what you think would be productive. But they can certainly be helpful. We do recognise there may be some points where it's not appropriate to meet with a complainant, and that can be the case when the relationship between you and the complainant has broken down to such a point that it's not going to be productive. But those instances are generally rare. There are a few things that I feel we have to mention, because people find complaints very stressful and can make misjudgments in that context. Firstly, don't panic because you've received a complaint. Take time to think about it and seek advice. Never amend previous notes. Excuse me. Avoid the temptation to disparage a colleague or to cast blame in that way. And whilst there's often a pressure of time, either from yourself or from an external party or an organisation saying, look, we must have your response, it's really far more important to get the complaint response absolutely right. And the first time you respond, that's the best chance you've got to do it. If the first response is not accurate or has mistakes in, or you've omitted something simply because you've not had access to the notes, that can reduce the level of trust between you and the complainant, and it can make subsequent correspondence very difficult. So to try and move this on, and this is where I will need your input, I'm going to put to you a couple of complaint scenarios. They're fairly generic ones, and they could reflect either primary or secondary care. The first is a complaint from the daughter of a 79-year-old patient. So here, the patient attended, was assessed and was treated with antibiotics for a chest infection. Unfortunately, as some people do, she deteriorated later that day and had to be readmitted to hospital. So that's the complaint scenario. There are a few issues that arise from that, and I'd like you to let me know what you identify from that scenario. Again, use the chat box, and I'll leave the scenario up so that you can refer to it as you do that. So we've got a lot of really helpful comments coming through here. A lot of you are asking, well, look, was the patient properly assessed the first time? Was there a proper history taken? Was she examined properly? And I think all those referred to what a few of you have said here, which is that we need to establish what happened in the first consultation. So of course you probably need the records, you'd probably need to get an account from the person who was doing that assessment as well. The other thing which a number of you have identified is absolutely right, but this is a complaint from a relative. So you'd need the patient's permission in order for them to bring a complaint on the patient's behalf. A lot of you have mentioned things such as the CURB score, and I understand that's a risk score for stratifying a pneumonia. And that goes again to looking at the quality of that initial assessment and seeing whether that was right. And a lot of you picked up that the second doctor who saw the patient admitted the patient straight away, and that's made you think, well, look, was that first assessment right? So I think that's really helpful, and you've got the issues that I draw out from that. I mean, I think the key thing here is whilst we may look at this and think, well, look, something clearly went wrong here, it still it still needs proper investigation. It may be that there was a very different set of circumstances, or the condition of the patient changed, and that's why you really do need to have the notes and account from the people involved in order to be able to respond and look at that properly. So the next slide is really to deal with one of those issues, which is the issue of consent and confidentiality, in that it's easy to be caught out by this when you're handling complaints. Essentially, where you're dealing with an adult with capacity, they have to authorise another person to bring a complaint on their behalf. Now, there can be complexities around that, in that somebody might ring up the practice and complain about the interaction they had with a member of your practice staff or with a given individual, and of course that you may be able to deal with on its own merits, providing you're not disclosing information about the patient. But in a broad sense, be live to that issue of capacity and consent when a complaint is brought by a representative or a relative on a patient's behalf. It can be quite a sensitive issue, and a lot of practice managers in particular think that if they say that, the family will think you're trying to avoid the issue. But I think the issue of consent remains important. It is the right thing to do to make sure the patient stands behind the complaint. And you can give reassurance that this won't delay the response. And what I would say is, if you're waiting for a complaint, for consent, make sure you get on and investigate the complaint, so when that consent comes through, that you're able to respond in a timely fashion, and that will reassure the complainant that you were simply doing the right thing. Also, just draw to your attention that there are categories of people who can complain on behalf of a complainant, on behalf of a patient, sorry. Of course, the person who was treated can complain. Any person authorised by the patient to act on their behalf can complain. A representative can bring the complaint when the patient has died. And a complaint can be brought by somebody else on behalf of a relative, behalf of a child, though as the child gets older there may be a stronger reason for thinking that the child should either bring their own complaint or agree to it being brought. And of course the complaint regulations do allow an adult who is incapacitated either because of a mental disorder or of a physical disorder to bring a complaint. Now, there are complexities around this. This is the details of exactly what qualifies a person to bring a complaint on somebody else's behalf does vary between the jurisdictions. And also there can be issues in terms of capacity, as in, there may be some circumstances where it's anticipated the patient will recover quickly, they wound up in hospital and they're not well, but it's expected they'll recover quickly, where it may be appropriate to await that. So this is another area where I'd say that if you've got questions about this in individual cases, then do come to us for advice. We're very happy to do that. So next I'm bringing you another scenario, and again it's one that you can imagine from hospital practice or from general practice. And of course a lot of our patients are very busy, and to deal with their healthcare can seem a bit of an inconvenience, and they will often have to take time off work, and if they're delayed in that because we're under a lot of pressure in the clinics or the surgeries are running late, well, they may have a limited amount of understanding for that. So in this case, this is a chap who commutes to London every day for work. He's taken a day off to come to see you. mentions a couple of problems, and you focus a lot more on some worrying back pain rather than the rash. There's a blood test that's necessary. The patient's not happy with the arrangements around that, and he's also not happy with the way the doctor actually did the blood test. We then go on to the issue of the result being communicated, and again they're unhappy that the result wasn't simply provided to their wife, and then there was an issue with the sample, and now it seems that there's also an abnormality on that blood test, and the letter continues. Now, I don't want you to read too much beyond that into the scenario, or we don't need to think about what the precise diagnosis might be, but again I'd really like your thoughts on what sorts of issues that scenario generates. So we've got a few issues here, and I think we've got now let me have a look through these. Yes, firstly, I think quite a few of you said that, look, it is quite appropriate that the wife wasn't given the blood results, and that's, I think, absolutely right, unless there's a consent in place. A lot of you have referred to the pressures of working to time in this, dealing with multiple complaints at once, and the risks involved in that, and I think that's absolutely right. And that could also have led to the fact that the patient felt that not enough time was given to them. And you've also identified there's lots of issues here, and you need to address each in turn. And maybe there may be an issue about communicating to patients in general how they can access their test results. And so there's an issue of communication that comes around this. And, I think some of you also quite rightly identified that there may be issues with the individual clinician here or what happened, but there are also some systems issues in terms of, well, why was the surgery or the clinic running so late? Is that something you should look at? The other thing I think has come out here, it really relates to the consultation itself, which is that, the fact that there were all these aggravations perhaps made the patient a bit less tolerant of getting a bruise during the blood test. And I think that's a very, very well-made point, in that effective communication, a good rapport with the patient, can make them a lot more tolerant of things that perhaps weren't there. And some of you said, look, should the doctor really be doing this? Were they skilled enough in doing it? And from the scenario, I guess we can't tell. It may have just simply been a normal procedure, someone with difficult veins who got a bruise. Or it may be that that the person really wasn't particularly skilled in taking blood, and there was an issue. And some of you felt here the patient didn't feel listened to, and that may be the case. Although the doctor focused on the more significant problem, then perhaps there needed to be some explanation about that. You've also said here that some patients may have unrealistic expectations, and that can certainly be the case, and that of course raises issues about how those should be managed, particularly when you're trying to deal with complex things in a short consultation. So that's been a really helpful set of comments, and I think again you've identified all the key points there. So the issue I want to draw out from this is that this is the type of complaint you sometimes get when there are multiple issues. There are issues around systems, there are issues about the consultation, and there are things that happen afterwards. There are issues relating to a sample being mislaid in the lab. So make sure you identify all of those so you're able to investigate those properly, because the approach to each thing may be different. This is, say, if it happened in primary care, you may well need to contact the hospital laboratory and say, look, can you tell me what happened with this sample? Are you able to give us an explanation? At least we can reassure the complainant that we've looked into that. So I think this is, there's lots of interesting things in the scenario, but if you're handling complaints and looking at this, I'd say also, look out for things like this, where there are multiple different issues that need to be investigated in a different way. This is a type of complaint where I'd say it is helpful to consider a significant event analysis or an adverse event review, or some kind of reflective process to look at what's gone on here. It helps you identify the key issues, and as a lot of you have pointed out in the comments, there are certainly areas of positive practice, the approach to confidentiality was probably appropriate. There may well be issues about how those things are communicated to patients in general. But that's clearly there. The doctor at the end of the day went out of their way to deal with a couple of problems and to take the blood test themselves. So it's not that there are only negative things here, but look at the areas of concern also. This is the sort of complaint where you may have suggestions to prevent a recurrence. This may be looking at appointment scheduling, as a lot of you have said, about phlebotomy resources, about the way you tell patients when they register or access your service about how test results will be dealt with, and the issues of confidentiality. The broader point I want to draw out here is that where you come up with positive recommendations, then try and be specific in what they are, agree what the action is, and assign some responsibility for who will implement those, and have a review date so you can check they've actually been implemented. The reason I say that is that, of course, that's the right thing to do and that's effective governance, but also from a more selfish perspective, if this issue doesn't go away, if the Ombudsman is involved or there's a complaint to the GMC or what have you, then having a good complaints response and demonstrating that the issues raised from it have been dealt with effectively is incredibly helpful in being able to deal with those things, whereas assurances that some things will be done with a lack of action there afterwards can raise further questions. So that's a really important element that I draw from actioning points that you've identified. The final thing I want to really talk about in any detail is the issue of meetings with complainants. The reason I bring this up is it's a question that we're often asked, and meetings are sometimes really good ways of resolving complaints, and they can be particularly helpful when you have a risk of ongoing to and fro correspondence where perhaps the messages aren't being properly transmitted between both sides. You can certainly have a meeting at the outset of your complaints procedure if that's the patient's preference, or if you think that will be the best way to resolve it. Bearing in mind that even if you resolve things through a meeting, unless it's one of those oral complaints resolved within 24 hours, you still have a duty to write to the complainant with a response to the complaint. Now that may simply be a summary of the meeting, but the formal obligations that deal with a complaint, that arise from a complaint, are still there even if you deal with it by means of a meeting first. Now, in terms of handling such a meeting, I think there are a few things that I'd say. First of all, think about why you're having the meeting. Try and set an agenda, and that's, I think, particularly important when you're dealing with complaints where after you've issued a response and there are unresolved issues. I think it's important to identify those issues where there's scope for further discussion, the issues which you'll discuss but are unlikely to be resolved because people have a fundamental difference of opinion or view of the facts, and get everyone to sign up to that agenda. Again, if you're dealing with a complaint, with an oral complaint by way of a meeting, then set out what the complaint's about, because actually people don't always express themselves clearly, and what we may note down as thinking is their key issues of complaint may not be. So put those things together. Somebody's asked a sensible question here about, well, look, what do you do if a complainant says they're bringing a lawyer with them to the meeting? Well, again, that's the sort of thing where it suggests to me a complaint that's moderately complex or has got an amount of heat associated with it. I'd always say if you face that situation, then contact us for advice to talk through the whole scenario that's led to that point. But in terms of dealing with that question of a lawyer, well, what I would usually advise in that situation is it is appropriate often for a patient to be supported at a meeting, and particularly where complainants are vague or where they've got unrealistic expectations of what they can achieve through a complaints process, then having a friend present or a trained conciliator or someone from the local advocacy service can be entirely appropriate. I would say that it's not appropriate that they should have a lawyer with them, in the sense that this isn't a claims process. It isn't a formal legal process that's intended to determine rights and wrongs in that way. It's an attempt at local resolution to try and resolve things between the complainant and the person or the organisation they're complaining about. So I think in terms of practical steps, if someone says, well, I'm bringing a lawyer with me, I would tend to point them towards these alternative sources of support. In terms of other facilities you may have available, I would say that these facilities vary from region to region. Sometimes having a trained conciliator can help where there are really entrenched issues. Sometimes where there are clinical issues and the patient simply after reassurance that an independent set of medical eyes has had a look at that, then that can be really helpful as well. So I think what I'm saying here is, look, have a plan when you go to a meeting, decide what you think you can achieve, agree what's to be discussed, and try and do that in a disciplined way. I've got a question here that says, how would you decline their offer? And I think that's that probably relates to the issue of whether there is a whether they plan to bring a lawyer to their meeting, and you say, well, no, I don't think that's appropriate. I would say in terms of precisely how you do that, I'd encourage you to contact us for advice on that, because I think how you do that depends on the individual circumstances. Sometimes people will say, look, I'm bringing a lawyer because I want to bring a claim. Well, then actually it's relatively straightforward to decline that, because you would politely simply say, well, if you want to bring a claim, then of course you must take legal advice from your lawyer and submit the claim if you think that's appropriate, but that's not appropriate for this forum. In other circumstances, as I say, there may be the polite way to do it would be to offer an alternative route, but that really does depend on the circumstances. So, that's one way I'd say, look, we want to see the papers and we can give you specific advice on how best to approach that. Whenever you've had a meeting, do take minutes of it. Somebody should attend as a note taker, and I would encourage you to share those minutes with the complainant and have them agreed. It's again partly because I think that's a sensible way to conduct any meeting, so that everyone has at least some common ground as to what was discussed, but also because it reduces the risk of this issue coming back again and people disputing what was discussed before. Sometimes you can get in very difficult situations where patients simply won't agree with what you've written in the minutes and have their own version. In those circumstances where it can't simply be dealt with by way of agreed amendments to minutes, I'd say simply file their comments along with yours, and then at least you've got a document of that dispute. And I think Anu has made a really sensible comment here in saying, in my experience, meetings with complainants are usually very effective, but allow at least 1 hour longer than planned. I think that's very sensible advice. Another question here is it worth recording the meeting and just taking minutes? I think, that's really a matter for judgment, really. I think if there is very likely to be a dispute, then recording it and having a transcript made up is perfectly reasonable. The only thing I would say for that is make sure that everybody understands the meeting will be recorded, make sure everybody knows that's happening in advance so there's not a standoff or a dispute when you have the meeting, and provide that transcript to all those that were there. Now, so I'm sorry, I'll deal with one other question first, is how do you choose an independent clinician? Will they have an idea about your speciality concerns? Thanks for that question, Osman. I think it really, again, it depends on the circumstances. I think there's two elements to it. One is obviously the clinician should have meaningful independence, so should be outside your immediate circle so they can look objectively at those things. In terms of how specialised they need to be, I think it depends on what the issues are. There may be some in terms of generic issues of practice that a generalist from your own speciality can deal with. I do agree that there can be issues if you work in a very subspecialised area, and that doesn't always make it possible to do this. But those issues tend to be relatively few and far between. subspeciality issues, I would say, are fairly common in terms of claims that we deal with, where there are very specific issues of management that are at issue. In terms of most complaints, they don't tend to focus on the minutiae of clinical management. Now, there are obviously exceptions to that. So I would say, look, you can use your judgment on that and see what's appropriate. So if you've gone through the process of, you've identified your complaint, you've acknowledged it appropriately, you've put forward a really detailed response, and then you've had a meeting to deal with those outstanding issues, what then? Well, the requirement from the changes made to the complaints regulations in 2009 were that all complaints must be, in inverted commas, signed off. And what that means is that you must formally indicate that you've reached the end of local resolution to the complainant. So you must say, well, look, we've now got to the point at which, we've done all we can to resolve your concerns, and all complainants now must be advised of how they can seek independent review of this matter, and that's a statutory requirement stemming from the complaints regulations, and the review is now from the Parliamentary and Health Service Ombudsman. If you're responsible for handling complaints in general practice, that duty will fall onto you if you're the responsible person for complaint. In an organisation such as a hospital, often the complaint responses will be signed off by the chief executive with this information in. Often doctors are slightly wary about this, saying, look, are we inviting trouble? I would say you're certainly not, because A, it's a statutory requirement, so you kind of have no choice. The second thing is most complainants who are motivated and aren't going to let go already know this, or this route, and they'll make an issue of the fact that the letter doesn't comply with what's expected of it. So make sure you also draw the process formally to a close as well. So that's all I had to say about this process. You've been really great in terms of your contributions, etc. so far. And I think, I'm preaching to the converted here, but I'm going to talk very briefly about how to avoid complaints. The first thing I'd say is that there is no way that we can absolutely avoid complaints. People are encouraged to complain and to provide feedback to the NHS. It's seen as a mechanism of improvement, rightly or wrongly. And so it's likely that we'll all end up with complaints through our careers, and it is part of practice, and the skill is as much dealing appropriately with complaints as avoiding them. But there are still some things which I think a lot of you have brought out in your comments. Maintaining good communication can be extremely helpful and can sometimes mean that complaints don't arise even where things go wrong. Keep good clinical records, involve senior staff in service development. By that we mean where there are learning points to be implemented, make sure that someone senior drives that as well so they happen, and also have senior staff involved in managing your complaints process. Ensure that your staff are appropriately supervised, and I mean both clinically and also in terms of how you handle complaints. It sounds trite to say take guidelines into account, but the point that I'm making here is that guidelines the guidelines are often available, or universally available in the public domain, so your patients may well have access to them. So take those into account both when you're managing patients and when you're assessing whether your management of a situation was appropriate if you're responding to complaints. As a point that's been made by you, work within your competence and expertise and keep up to date. Those again are fairly obvious things that I'm sure you're all familiar with. I guess that we are seeing a fragmentation of practice and a subspecialisation, and as well as saying, look, make sure you're competent and keep up to date, collect evidence of that as well. Now, we all do that for revalidation and appraisal. For things like if you do minor surgery or practical procedures, keep audits of those so that you can reassure complainants or anybody else who has an interest after an adverse event that you have acted appropriately. So there's a few other things that have come through. I've got a comment here from Nicola saying be nice. I think that's extremely sensible, that being nice to people avoids a lot of complaints. Signpost the patient journey. I think that's absolutely right as well. Make sure people know what to expect, because sometimes something happening that's not necessarily wrong but unexpected can lead to a complaint, and ensure they know what happens next. And we've had one question from Peter about whether you can listen to the seminar later on, and you can, and that we'll be posting this on the website once the recording's been downloaded, so absolutely. And so we've had another few comments here which I think is helpful from Amit, saying that I've started explaining what would happen next, what tests the patients might need if the patient isn't better. So if you're not better, you might need a gastroscopy, or we may need to refer you on. I think that's really helpful, both in terms of expectation management and also in primary care, where often the doctor's given safety netting advice, but the patient might not have registered why that's important. So saying, giving positive advice, saying, look, if this isn't better, come back because I want to do these things, can be really helpful, and it can also be helpful in defending your management and responding to the complaint. And you've said here, who to call if they've not heard, and I think that's also incredibly helpful, particularly with regard to complaints and referrals and things like that. Look, if you've not heard about this referral, then contact us on this number. It also touches on a point with complaint in that we know that there's often a real rush to respond to a complaint and a pressure of time. I'd say, look, it's really important to get it right, but make sure you keep your complainant updated during that process. Let them know why there's a delay and when they can expect to be updated again. So thanks again, lots of really helpful suggestions there, born out of practice, which I think are really excellent. And now I'll open you up to some questions here, and I've got a few coming through, and I'll just consider these and get back to you. So we've got here, if a patient rings the practice manager and says she's been mismanaged by a particular GP and also the hospital, and now her next stop is a solicitor, how should you respond? Well, I think in that case, what I would do is to say, look, it's entirely up to you as to whether you want to take legal advice, and we of course respect that. If you want to use our complaints procedure, then here are the details of it. So I think, in that situation, clearly the patient's unhappy, but they've not really been clear as to how they want you to deal with it, or whether they want your involvement, or whether they simply want you to know that they're going to a solicitor. So I would put the ball back in their court and say, look, we're happy to look at your concerns if you have them, but if you prefer to go and see a solicitor, then, that's up to you. The next question I've got from Louise here saying, I feel in radiology we're very vulnerable, limited scanner time, and sometimes you have to delay scans and then retrospectively find a serious abnormality which you could have found earlier. I think that's right. I think there are some, any speciality where you've got a throughput is difficult. You are allowed to prioritise your caseload, and that's expected. The GMC expect that as well, but individual patients certainly do sometimes struggle to realise that. Where you get that sort of complaint, there will be, it'll be obviously for the doctor to justify why they have afforded a given priority given the workload on the day. But of course there may well be issues for the organisation in terms of capacity, etc. So I would say it's important to involve your management in that sort of complaint as well. And Anu said here, identify it as a complaint, sometimes a key issue that we've never managed as a complaint. I think that's absolutely right. It is great to be able to resolve things orally straight away. There are other issues, particularly where a complainant has got recurrent concerns, where actually having a process that you can have a structure to can be really helpful. So we've got here, if we get letters from solicitors asking for patient notes, should we start talking to the MDU at this stage? I would say, absolutely call us and we can talk through it. Some requests for information are because the patient wants to take a slip, trip and fall claim. Others are in the initial stage of a clinical negligence claim. And, without being disparaging to claimant solicitors, the practice at this stage tends to be to try and involve as many people and stages of the patient's care in a claim. So you may well get correspondence after that, so please do pick up the phone to us. So I've got here, what about a non-clinical complaint about inappropriate behaviour, how to investigate and respond? Well, again, I would say that depends on the specific circumstances. The general point I draw out is that the complaints regulations don't draw out, draw a distinction between clinical and non-clinical complaints. The difficulty with these, of course, is you're often looking at one person's account against another, and the question you've asked here about inappropriate behaviour of a specific doctor, well, again, I think it depends on what's assessed. If it's a concern about rudeness or what have you, well then often you'd go about it in the normal way of getting an account from the doctor, looking at the clinical records and putting together a response with that. If there are more serious concerns suggesting an indecent assault or something like that, well there may well be very different circumstances, and even regardless of whether the allegation is credible or whether it's made out, there may be steps the practice needs to take, and I'd always say, look, ring us for advice in those circumstances. So the next question I've said here is, you mentioned at the beginning of the seminar that most complaints should be considered formal. Is there a duty of manager to keep a record and a duty to discuss in the team as learning points for all team members? I think there's a couple of separate issues here. And whilst I didn't want to get too into the complaints regulations, yes, there is a duty to keep a log of complaints, and there are various reporting duties in the various jurisdictions. Northern Ireland require quarterly reports with a report sent within 3 days, an anonymised copy of the report sent within 3 days of the complaint response being issued. In England, the position is that NHS England will expect an annual complaint summary with you classifying the nature of the complaints you've had and which have been upheld or not. So yes, absolutely. And again, I think this does link into the governance thing, in that if there are learning points, then it makes sense to share that within the team, and I think that is part of effective clinical governance. I wouldn't say that there's a duty for every single issue to be raised at that meeting, but I think that there's certainly an issue in terms of looking at those issues and seeing that. So we've got a few coming in, and I'll try these. I've got a general question here about prescribing without seeing the patient. I think that it is of course always easier to defend a prescription when you've got an up-to-date assessment of the patient, but it is recognised that there is, prescriptions are issued remotely and by telephone, and we have to work with repeat prescribing systems and similar. The GMC does really detailed guidance on managing medicines and devices that deals with that. And in essence, what you have to be able to justify is that you've got proper systems in place, say, for repeat prescribing, and if you're prescribing remotely, that you've got enough knowledge of the patient and their condition to be able to justify that. So I've got here, in a full-partner practice where the doctor regularly covers for each other's leave and days off, if a patient absolutely refuses to see one's doctor, is it reasonable to ask them to change practice? I think this is I guess it's a slightly different issue to complaints, but it's one that does come up quite a lot. What I would say is that usually this sort of thing arises when there's been a patient that's had a fallout and says, I never want to see that doctor again. I think the right thing to do at that stage is to say to the patient, okay, well, we'll try and accommodate your practitioner preference, but you should understand that these are the limitations upon it. There may be emergencies, etc., where that's not appropriate, and if you're saying that you absolutely wouldn't see them even if you were an extremist, well we can't provide safe care to you on that basis. And you may want to register with another practice. So it can be issues about removals often lead to intractable complaints, so ring us up for advice on those cases. But the key point I think with that is go to, when that issue first arises, try and manage the patient's expectations at that stage. I've got here, how long do the MDU think the average consultation should be over a session? At present I'm getting no complaints, lots of positive feedback, but pressure to keep from GP out of hours to keep 10-minute appointments. I would say, look, I think you should probably go back to the Royal College or on that, because we've never said, look, you must take, you must have consultations that are a minimum time or a maximum time or what have you. And of course, the amount of time you need for a given patient depends on the circumstances. Personally, I think, when you shrink much below 10 minutes, you are probably at greater risk. But I think it's better to probably go to a professional association or a Royal College to see what they have to say about that. So you've said here, if I have to answer a complaint about a doctor who no longer works for our organisation, do I have a right to contact the doctor, given they're no longer an employee? I would say absolutely, because the complaints regulations require that you effectively investigate a complaint. And if you're dealing with a complaint about a clinical matter where the patient's saying, why did this person do that, then I think that's an essential part of your complaints response. In terms of the obligations on doctors, the DNC doesn't time limit its obligations in terms of providing an explanation to a patient. So, I think it is perfectly reasonable that you go to, get the permission of the patient and say, look, this doctor's moved on, but I'd like to contact him with your complaint. Can I do that? I think that's appropriate. In terms of how appropriate is it for a GP to raise a concern, make a complaint, informal or formal, about a hospital service or the management of a patient in hospital, well, I would say that, look, if you have concerns about how that's been done, then you should raise that concern. How you do it, I think, depends on the circumstances. It's perfectly reasonable to pick up the phone and say, look, I don't understand or I don't like what's happened here. I think, the next part of the comment is to say, should a GP keep quiet? We don't live in glass houses. I think the difficulty with that, and I understand exactly what you're saying here, in that certainly my clinical practice is not so perfect that I can criticise everybody else with impunity, and we certainly have personal experience of people who've taken that route and struggle. I think the difficulty here is that, of course, we're in a culture at the moment where there is a lot of emphasis on raising concerns, and you can face subsequent criticism for keeping quiet. There's usually a diplomatic way to properly raise your concerns and have a record of that, so I'd say yes, do that. A scenario where someone in High Street indicates to a patient they have a wrong type of operation, the patient complains. How do you deal with this? Well, it is difficult because there are multiple opinions out there, from the television, from the man in the street, from everybody else. I mean, I would say that you deal with that on its own merits. The fact that the patient has had their concerns stroked up by somebody ill-informed is irritating, but I wouldn't let that irritation show when you respond to that complaint. Just deal with that in the way you normally would, provide an explanation, explaining why you manage the patient in that way, and that's sensible. So we've got, what if a member of staff wishes to complain about a patient? Well, I think, the complaints regulations specifically don't deal with complaints from staff about patients, that they're not in that. I think it really depends on what's going on there. If you've got patients being aggressive or abusive or what have you, you can use your own policies about that. And of course, there's the importance of providing accurate and proper warnings to patients about their conduct, so that, if the relationship breaks down, there can be a basis for removal. Again, we're happy to advise on those sorts of circumstances. So I think the important thing is that if a member of staff wishes to complain, make sure you've got a record of what the patient said to have done. Normally, it is appropriate that you share that with the patient, because often what we see is that everyone's trying to smooth things over, and then something catastrophic's happened, so that the patient has to be removed, and they will say, well, look, nobody warned me or told me that my behaviour was appropriate. So that's, I think, as much as I can say about that here. I'm rushing a little bit because we're out of time, and I'm trying to get through the questions. So if you write notes about a consultation, is it legally acceptable to make an electronic note afterwards instead, or is it acceptable the notes are scanned in and then destroyed? I think you can take either approach. The advantage of keeping the original record is, of course, that was written at the time, and no one can argue about that content or having been edited or rephrased. I appreciate there could be an issue if your document management system is different from this kind of journal, and it's perfectly acceptable to scan your home visit note in and then to summarise it on the screen if you want. So what can you do when the patient threatens to complain because you've not provided what's necessary, an unneeded home visit or antibiotics for a virus, etc., even when you're trying to give a full explanation? I think that you should manage the patient as you would otherwise, and you say to them, look, if you want to bring a complaint, this is how you can do it. Now, that is hugely frustrating, but I think that you've got to strike the balance here. One thing is, don't be intimidated in modifying your medical judgment and good judgment and doing something that's objectively inappropriate simply because the patient threatens a complaint. But if a patient wishes to complain, then make sure they've got information about your procedures and deal with it in the usual way. And of course, there may be other issues that arise from that if you've got ongoing difficulties in the relationship, in terms of repeated unreasonable requests, and there's ways to manage that. As I've got a comment here saying, well, look, what about indicating the patient can have a second opinion? well, that can certainly be appropriate in some circumstances. I'm not saying that's mandatory in every case, because I think what's being referred to is a lot of sort of minor niggles about minor illnesses and things like that, where the patient's got a strong opinion. But where there's an intractable dispute, certainly a second opinion can certainly be helpful. So I think we've reached 12 o'clock here, so I'm afraid I'm going to have to wrap it up here. But thank you all so much for that really interactive webinar. The questions are really illuminating, and a lot of really helpful points that you've put in here. They've been really excellent, and thank you for your participation and for sparing your time.